Welcome to your first pharmacology pre-recorded lecture, Introduction to Pharmacology. Here are a list of the learning outcomes. So if you're asking yourself what will be on the exam, this is what you want to look at. So exam content can come from the pre-recorded lecture, the PowerPoint, or live class activities. So our class meetings on Tuesdays. All of these things will tie back to the learning outcomes for that day. As we move through the lecture today, I will mention which slides tie to which learning outcome for the first few slides. This is just to get you used to how you can see how these slides and materials tie back to the learning outcomes. I won't do this for the whole presentation because you'll see as we start moving along that it's pretty self-explanatory and it follows a good logical order. The other good use of these learning outcomes, along with the handouts, which would be the PowerPoints, would be to help guide your reading. So if you choose to read the textbook, I recommend using the learning outcomes and the material in the handouts to guide your reading. The reason for this is because the pharmacology textbook includes a lot of information that we don't test on. If it's not a learning outcome, if it's not in our pre-recorded lecture or our PowerPoint, it will not be on the exam. The one caveat to this is if we tell you specifically in the lecture to go to a certain page or look at a certain box or figure in the textbook, you should do that. So you'll see that a couple times throughout this presentation that I refer you back to the book. In those cases, you do want to go look at that section of the book so you know what was discussed. So let's jump into pharmacology. So what is pharmacology? And this ties back to our learning outcome one, define pharmacology and pharmacotherapeutics. So pharmacology is the study of the biological effects of chemicals. Drugs are chemicals that are introduced into the body with the intent to cause a change. When drugs enter the body responds by trying to handle the chemicals by breaking down and eliminating them. Pharmacotherapeutics is another term for clinical pharmacology. This is the use of drugs to treat, prevent, and diagnose disease. And we're going to focus in on the drug's effect on the body and the body's response to the drug. Controlled substances. This slide and the next one ties back to learning outcome number 2, describe federal oversight of drugs. So in 1970, there was the Comprehensive Drug Abuse Prevention and Control Act. You don't need to remember that name. But that legislation is what led to the coding of drugs and the enforcement of codes to fall under the FDA and the DEA. And the DEA is the Drug Enforcement Administration, and that's under the US DOJ or the Department of Justice. So, any drug with an abuse potential, either physical or psychological dependence, is considered a controlled substance. The DEA monitors the prescription, distribution, storage, and use of controlled substance drugs in an attempt to decrease substance abuse. Local policies and procedures may be more rigorous than federal ones. The schedule of controlled substances, box 1.2 in your textbook, so you'd want to refer back there and take a look at that, goes a little bit more into depth than this. So the Schedule 1 drugs, also sometimes called C1 drugs, there's no current accepted medical use and there's a high potential for abuse. Schedule 2 drugs, there's a high potential for abuse. Potentially, there could be severe psychological or physical dependence, and these drugs are considered dangerous. But there still is some medical use for it. So, an example of this is cocaine. We know cocaine can be highly abused, and it's also can cause a lot of dependence on the drug. People can become addicted to it. But it also does have a medical use. It causes vasoconstriction, and so sometimes it's used intranasally or in our nose in order to constrict those blood vessels to stop bleeding. So there is a medical use for the drug, even though there's a high potential for abuse and dependence. Schedule 3 has a moderate to low potential for physical or psychological dependence. The abuse potential is less than Schedule 1 and Schedule 2, but it's more than Schedule 4. Schedule 5 has a low potential for abuse and a low risk of dependence. Schedule 5, lowest potential of abuse. Limited quantities of certain narcotics will be present in the preparation. So these are things like cold medicines with codeine in it. And Schedule 5 drugs are generally used for antidiarrheals, antitussives, and analgesic or pain relief purposes. Oh, one thing on this last slide. You do not need to know examples of drugs for each of these categories because we can always look that up if we need it. So you will not be tested on what drugs. The box 1.2 kind of goes in depth into that. You don't need to know that. Okay, FDA drug risk classification, specifically related to pregnancy. So it's important to know that drug use during pregnancy, that no drug is considered to be fully safe. It's really the benefit outweighing the risk. And then we do have something called teratogenicity, and this means adverse effects on the fetus. So from 1979 to 2015, there was a category system based on letters that was used to convey risk to the fetus of taking a particular medication when pregnant. In 2015, a rule was made to phase those categories out. You may occasionally still see them, or patients may refer to them. The categories were A, B, C, D, and X, and they moved from a relative safety, so category A was considered to be relatively safe, to category X, which is no harm to the fetus. You most likely will still hear people, myself included, refer to drugs as category X to convey that they should definitely not be given during pregnancy. So you really don't need to know the old categories except for category X. You should know that that means that we don't give it during pregnancy. The reason that we moved away from the old categories was related to confusion with what the letters actually meant. The new classification system is meant to assist healthcare providers in assessing benefit versus risk of taking a medication while pregnant and in counseling and discussing this risk with pregnant patients. The idea is that the patient should be allowed to make an informed decision for themselves and the fetus. So instead of having categories, they just include a bunch of information about the risk. So there'll be risk information not only when the patient is pregnant, but also for patients who are breastfeeding or lactating, because many drugs pass to an infant in breast milk, and for reproductive potential. So if a patient is taking a drug and subsequently becomes pregnant or impregnates someone else, is there a risk to the potential fetus? While the new labeling system is an improvement over the old categories, it still does not provide a definitive yes or no answer in most cases. Clinical interpretation is still required on a case by case basis. Yeah, learning outcome number 3 is to differentiate between generic and brand name drugs. So, brand name drugs get their name once the drug has been approved by the FDA. The drug company gets to name the drug. Companies that research, test, and manufacture drugs make the brand name drug. They're more expensive. The drug formula is patented for a certain number of years after it's been approved, which means that no other company can make the medication, which is what makes it more expensive. And insurance companies may not cover brand medication. Generic is the original name given to the drug when it was submitted to the FDA for approval. So let's take a moment to differentiate that. So, because it sounds very similar to the brand name, but it's different. So, generic is before it gets approved by the FDA. Naming of a drug with a brand name is after it's been approved by the FDA. Okay, back to generics. So these companies don't spend money on research or advertising, so the costs are significantly less, and that makes the drug more cost effective for the consumers because the companies just manufacture the drug. They're not doing all the research into other drugs. They don't even advertise because it's a generic. They have the same active ingredients. So those active ingredients are bioequivalent or the same. However, inactive ingredients may vary. And this can cause some alterations in the drug, such as how the drug is metabolized. Most states require generics in order to keep costs down unless DAW, dispense as written, is on the prescription from the prescriber. And most generics are identical to the brand drug. They are safe, they're cost effective, and they only have subtle differences. Learning outcome number 4 is differentiating between over the counter and prescription drugs. And learning outcome number 5 is explain the benefits and risks associated with the use of the over the counter drugs. And that's what we're going to talk about here. So, prescription drugs require an order or a prescription by a licensed provider. Some over the counter drugs started as a prescription and then got changed to over the counter or OTC because they were found to be very safe and useful. Behind the counter drugs are a form of over the counter drugs. They do not require a prescription in most states or cities, but they're called behind the counter because they have been found to be used to manufacture illegal substances. So a lot of drugstores keep them behind the pharmacy counter, and you have to go up to that pharmacy counter in order to get the medication. They are still safe when taken as directed on the label. These drugs behind the counter may require a photo ID when you're purchasing them, and there may be limits on the quantity. So, what are some concerns with over the counter drugs? Well, they do mask signs and symptoms of an underlying disease. So, if I am coughing and decide to take an over the counter cough syrup, the coughing's going to subside. But if I'm still having some coughing, but it's better with the cough syrup, so I'm like, oh, I'm fine. And I keep taking that cough syrup instead of going to the provider and figuring out what's wrong, I might have a more serious issue going on. This is why it's important that our patients follow the directions on the label. Because if you ever look at the label of an over the counter medication, it usually gives you a time period. You can take this drug for this many days, or do not take this drug for more than 7 to 10 days. If you continue to have symptoms, follow up with your provider so that we can make sure that we're not masking the signs and symptoms of something more serious. It can interact with prescription drugs and interfere with drug therapy. So it's really important to teach our patients who are taking prescription drugs to avoid over the counter drugs without checking with this prescriber first to make sure that it'll be safe for them to do so. Serious overdoses can occur if they don't take the medication as prescribed. So, if they're taking more than the amount prescribed or taking it longer than they're supposed to, they can end up having an overdose. And a lot of times patients don't consider these drugs, so they don't report them to the provider, and the provider may not be aware that they're taking them. So it's really important that nurses specifically ask what over the counter medications are being taken as a part of our medical history. So we're going to move into two key terms for pharmacology and how drugs work in our body, and that's pharmacodynamics and pharmacokinetics. Pharmacodynamics is how the drug affects the body. So it's how the drug is actually doing its job in the body. Pharmacokinetics is how our body acts on the drug. I remember the difference by thinking of the D in pharmacodynamics and the fact that drug comes before body in that statement. So pharmacodynamics means how the drug affects the body. A way to remember pharmacokinetics is kinetic means movement. So pharmacokinetics is the movement of the body and how that affects the drug. So why are these two terms important? It's because it can determine our drug administration, how we actually give the medication. Knowing this information about pharmacokinetics and pharmacodynamics helps the nurse to anticipate therapeutic and adverse drug effects, which can help to determine the interventions that we're going to do to make the drug regimen the most effective for the patient. So we're going to go through these a little bit more. Pharmacodynamics, so how the drugs work in the body, is actually pretty short compared to pharmacokinetics. And that's because pharmacodynamics is the drug, how this medication is working in the body. And it's based on the drug, so it's not going to change. So the mechanism of action, or how the drug works, can work one of 4 ways. One, it can act on the receptor sites, which are located on the cell membrane. A drug that acts on the receptor site to enhance the naturally occurring effect is called an agonist. A drug that binds to a receptor site blocking the normal stimulation, so there's a decrease or no effect of the drug, is called an antagonist. There can also be a physical action. The drug can change the physical properties of cells and body fluids by changing the pH or damaging the cell wall. It can act on other chemicals in the body. Remember, drugs are chemicals, so it can be a chemical acting on another chemical because our body runs on continual chemical reactions. And when a new chemical, like a drug, enters the system, it can change or interfere with cell function. The last way that it can act in the body is through our enzyme or metabolic action. So enzyme systems work in a cascade. One enzyme is activated, which then activates another enzyme, which activates another enzyme, etc., until the cellular reaction occurs. If one of these steps is blocked, then normal cell function is disrupted. It can also work by speeding up the cascade, which then can end up affecting how the body responds. Pharmacokinetics is a much bigger topic for us to talk about. And that's because this is how the body acts on the drug. And even though we're all humans, we're all different. Even humans who have a lot of similarities still are different on the inside. And so we're going to see a lot of differences in how the body can act on the drug. And we're going to be talking about that. So first, we're going to go through some terminology. First is the timing of the drug. We have the onset when the drug starts to work, the peak when the drug reaches its most effective point, and duration, how long the drug lasts for, how long it continues to work in the body. With the exception of insulin, which occurs later in the semester, you do not need to know the onset, peak, or duration of individual drugs or drug classes. So your book goes in depth on individual drugs and their onset, peak, and duration. That is not something you need to know. Critical concentration is the amount of drug needed to cause a therapeutic effect. So there has to be a high enough concentration of the drug in the body to actually produce the intended or desired effect. This amount is figured out during the drug trials. The recommended dose that we see in the drug guide is the amount of drug needed to eventually reach critical concentration. Too much of a drug will have a toxic effect, and too little of a drug will not be therapeutic or it won't work. We also have something called the loading dose. Loading doses are higher than normal doses that we typically use for treatment. After we reach that critical concentration, then we'll go back to the recommended dosing schedule that we see in the drug guide. Some drugs take a while to reach critical concentration. A loading dose can get us to that critical concentration faster. Not all drugs, matter of fact, the majority of them need a loading dose. So we typically don't see loading doses except for serious situations with individual drugs. And we'll let you know about those drugs when we go along throughout the semester. Dynamic equilibrium is the actual drug level in a person's body. The word dynamic is used because there is variation amongst individuals. Dependent on how the drug is absorbed into the body, distributed to the active site, metabolized in the liver, and excreted from the body will depend on that dynamic equilibrium. Therapeutic index is the ratio comparing the blood concentration at which a drug becomes toxic with the concentration at which the drug is effective. So the closer that or smaller that therapeutic index, the more risk there is for harm to the patient. So if the dose that we need for the dose to work is very close to the dose that can be toxic in a person's body, that makes it a high risk medication. Okay, so let's go through the four main parts of pharmacokinetics. So we have what I remember as ADME, ADME, absorption. This is getting the drug into the system. Distribution, getting the drug to the target organs. Metabolism, also called biotransformation, making the drug active. And excretion, the process of getting the drug out of the system. So first we'll go through absorption. Absorption starts when the drug enters the body and ends when the drug reaches the circulating fluids and tissues. So this is moving the drugs from the point of administration to the bodily fluids. There are many factors that can influence absorption. First is route. IVIM, so intravenous or intramuscular, are the fastest routes to be absorbed. Table 2.1 in your book explains how the different routes affect absorption. Solubility, medications that are water and lipid or fat soluble absorb the fastest. Tissue perfusion, we need to have adequate blood flow. The tissue needs to be in good condition in order to absorb the medication. Ionization, no charge is best. Drugs that are positively or negatively charged are not absorbed as well. And size, the smaller the drug molecule, the faster it will be absorbed. Next, we move on to distribution. The systemic circulation distributes drugs to various body tissues. Distribution depends on the same factors of absorption, including lipid or water solubility, no electrical charge, and adequate tissue perfusion. Additionally, most drugs are bound to protein in order to be carried through the bloodstream to the target tissue. The more tightly a drug is bound to protein, the harder it is and the longer it takes for the drug particles to get free in order to cross the cell membrane. If the drug can't be released from the protein binding site, it can't work in the tissues. Only free drug particles can produce a therapeutic effect. Drugs can also be loosely bound. This means that they act faster and are excreted faster. You can also have multiple drugs competing for the same protein binding site. This can alter the effectiveness of a drug or result in toxicity. And we'll talk about toxicity in a little bit. The blood-brain barrier is a protective mechanism to keep bad things out of our central nervous system, or CNS. Drugs must be lipid soluble in order to enter the blood-brain barrier or to cross that barrier. This can create a challenge when we're trying to treat CNS conditions. Certain CNS conditions like brain infections can alter the blood-brain barrier if the infection gets bad enough, which will then allow protein-bound drugs through, which can create some problems. In a little bit, we're going to talk about CNS adverse effects. These effects are typically indirect and not actually the result of the drug interaction with the CNS tissue, since most drugs cannot cross the blood-brain barrier. Also, drugs can enter the placenta and breast milk, which can affect the fetus or the neonate. So we need to check those risks before administering medication, and we would do that in the drug guide. Metabolism is the body's way to get rid of a foreign or toxic substance. With drugs, the body changes the drug to be less active and more easily excreted. Most drugs are metabolized by the liver. The kidneys, lungs, plasma, intestinal mucosa also can metabolize some drugs, but the important one for metabolism is liver. First pass effect. Drugs administered orally are absorbed from the small intestine into the portal vein and then onto the liver, where liver enzymes break the drug into metabolites. The majority of metabolites are deactivated and then excreted. This means that a large portion of the oral dose is destroyed and never gets to the tissue. What is left after the first pass effect is transported through the body via the circulatory system to the target tissues. Parenteral medications like IV drugs, drugs that are administered through an injection, like into the muscle or the fat, those skip the GI tract, so it skips that first pass effect. They still undergo metabolism or biotransformation in the liver. However, some of the drug reaches the tissues before going to the liver, which means that the lower doses can be utilized. So when we're giving medications orally, those doses have to be higher than when we're giving them parenterally. We also have our hepatic enzyme system. Remember, hepatic means liver. So there are enzymes inside the liver cells that are responsible for metabolism of the drug. Cytochrome P450 is one of these enzyme systems and probably the one that we hear about most frequently. You hear about it sometimes on drug commercials, on TV or the radio. Different drugs are metabolized by different enzymes. When a drug is administered that is metabolized by a particular enzyme system, the presence of that drug in the system causes either an increase in the activity of the enzyme system, called enzyme induction, or it inhibits the enzymes. An increase in the enzyme activity results in an increase in the metabolism of the drug, so it's inactivated and excreted more quickly. If the drug inhibits the enzyme, then the drug will not be broken down, which needs to happen for excretion. This can lead to a buildup of the drug to a toxic level in the system. This is why liver impairment is a contraindication or caution when administering certain medications, because metabolism is affected. If two drugs are metabolized by the same enzyme system, they should not be taken together. If the drugs increase the enzyme activity, they'll be metabolized even faster than normal, and so they'll be less effective. If the drugs inhibit the enzyme system, then the drugs won't be broken down like they're supposed to, which means they can't be excreted, and it increases the potential for toxicity. Excretion is the removal of a drug from the body. There are many routes of excretion, including skin, saliva, lungs, bile, and feces. However, kidneys are most important and where most drugs are excreted. If a drug is water soluble, it can be excreted through glomerular filtration. This is the process by which water and water soluble components from the blood pass into the renal tubule. If the drug is not water soluble, then the active transport system can get the drug into the tubule by exchanging drug molecules for either acid or bicarb molecules. We should always consider a patient's renal function before administering a drug because kidney dysfunction or impairment can prevent excretion of the drug, leading to toxic levels in the body. Another key term or concept of pharmacokinetics is half-life. Half-life is the time it takes for the amount of drug in the body to decrease to 1/2 or 50% of the previous dose. So an example of this is that if a patient takes 20 milligrams of a drug and the half-life is 2 hours, that means 2 hours after administration, there'll be 10 milligrams of the drug left in the body. 2 hours after that, there'll be 5 milligrams left. 2 hours after that, there'll be 2.5 milligrams left. This is important because that's how drug companies have determined the duration of effect and timing of the doses. The way we know the half-life is by looking in the drug book. So our drug book or drug guide will tell us the half-life of every drug. There are many factors that can influence a half-life, so it's not exactly on the time that it says. It's what their testing told the drug companies during the clinical trials. So if the half-life is 2 hours, in one person it might be 2 hours, but in someone else, maybe it's an hour and 45 minutes. So factors that can influence half-life include absorption rate, distribution to the tissues, the speed of metabolism, and the speed of excretion. So our other key components of pharmacokinetics. The half-life that's listed in the drug guide is based on typically a healthy 150-pound male because that's typically who drug trials are done on. There are many factors that influence drug effects. So no two people are the same, which means different people are going to have different reactions to drugs. So some factors that influence drug effects include weight. So I just mentioned that it's a 150-pound male that we typically see drug trials being completed on. So patients who weigh significantly more or less than this may require different amounts of a drug. Age is a big factor. Children have immature organs and their metabolism is different than adults. On the other end of the spectrum is older adults. Polypharmacy or getting a lot of medications, less effective absorption and distribution, oftentimes due to fewer plasma proteins, less efficient perfusion going to those tissues, altered metabolism related to liver changes, less effective excretion due to decreased renal function can affect older adults. So most often in older adults, we need to decrease the dose. There's a mantra I like to remember with our older adults, which is start low and go slow. So we start at lower doses, and when we do need to increase their dose, you'll see providers doing that more slowly than on their younger counterparts. Gender can influence drug effects. So males have more vascular muscles, so the effects of intramuscular injections will be seen sooner. Females have more fat cells, so drugs that deposit in fat may have prolonged effects. There are physiological effects like hydration and electrolyte imbalance. Pathological factors, so the disease the drug is intended to treat can alter functioning of the chemical reactions within the body, which can change the response to the drug. Things like liver and kidney dysfunction, GI disorders, again, other diseases can end up having an effect. Genetic factors, there's something called pharmacogenomics, and this is the study of genetically determined variations in the response to drugs. This is a fairly new area that we are looking at, so we're learning more about this every time. But we learn that there are things encoded on our genes that affect the way that we absorb sometimes all drugs or sometimes just particular drugs. So I'm sure we'll continue to learn more about that in the coming years. Immunological factors, patients can have allergies to drugs because antibodies can develop to the drug proteins. Psychological factors, there's something called the placebo effect. If the patient thinks it's going to work, they often feel like it's working for them. And then there's also been studies that show that patients who have a positive attitude in general tend to have medications work better for them. Environmental factors, so atmosphere, mood, temperature of the room, all of those can have an impact. It can have an impact on drug effects. And then tolerance. So drug no longer has the same reaction, so larger doses of medication are needed. This can be prevented sometimes by giving a drug in smaller doses or combining with other medications. So you might see providers doing that. And cross tolerance can develop. So if a patient, say, develops a tolerance to one opioid, they could have a cross tolerance to another opioid as well. And then accumulation, this is where toxic levels occur and we see adverse effects. So we need to be sure to follow drug regimens precisely. Drugs taken more frequently than recommended or at incorrect times. For instance, if they're told to take something twice a day and instead of doing that, they decide to take 2 pills at once. The body might not excrete the drug properly. That can lead to accumulation and us seeing toxic effects. When 2 or more drugs or substances being things like herbal products or certain foods, are taken together, an interaction can occur. It might not, but it can. These interactions can occur at the point of absorption, distribution, metabolism, excretion, or the site of action. So, for example, if a patient takes tetracycline, which is an antibiotic, with dairy products, the drug ends up not getting absorbed, which results in a decreased therapeutic effect. So that would be like a drug food interaction. So we can see with these interactions an increase or decrease in therapeutic effect, an increase in adverse reactions. Drugs with narrow margins of safety. So this is like therapeutic index. The safety margin is the difference between the dose required to produce the therapeutic effect and the dose that causes harm. So a narrow or small safety margin would be when these two numbers are close together. Interactions are more likely to cause significant issues when there's a narrow margin of safety. And that's because even small changes in pharmacokinetics or pharmacodynamics can alter the amount of drug in the body. Drug-drug or drug alternative therapy interactions, we need to remember that we're not just talking about traditional medications, but also alternative or complementary therapies, herbs, supplements, vitamins. Those all can have an effect. Drug-food interactions typically occur when there's direct contact in the stomach. So spacing the interacting medications out usually solves the problem. The exception to this would be grapefruit juice. Any drug that says not to take grapefruit juice means no grapefruit juice at all. Even if the patient normally takes the medication in the morning and they're going to drink grapefruit juice at night, nope. In this case, we don't have the grapefruit juice at any time of day. Oral medications in general are usually best on an empty stomach due to absorption. So this would be 1 hour before or 2 hours after the ingestion of food. There are some exceptions to this, especially since there are many medications where the rate of absorption doesn't matter. So for example, acetaminophen, it really doesn't matter how fast it absorbs, so it wouldn't matter if you take food or do not take food. Also, some medications may be able to be taken with food if a patient can't tolerate it on an empty stomach. So like if they get severe nausea with the medication. Drug laboratory test interactions. So, administration of a drug may alter test results. This may be the result of the drug, not an actual problem in the body. So, for safety, you always want to check the drug guide or the drug monograph. That's the insert that comes with the drug for drug alternative therapy, or drug food interactions. Optimal therapeutic effect. So I know a lot of this that we just talked about might seem really scary, and it is important as nurses that we are knowledgeable about the medications that we administer and that the patient are taking. It's always better to avoid problems as opposed to treating them after the fact. However, most patients achieve optimal therapeutic effect with their medications with minimal adverse reactions. That's why so many people take medications. If they all caused all these horrible problems, people wouldn't take them. So, what can we do to help? Well, in addition to us being knowledgeable about medications, we need to get a complete patient history. We need to know about any disorders, diseases, surgeries they've had. We need a full medication history, including herbal supplements, vitamins, over the counter medications. The best way to do this is to specifically ask if they're taking any herbal supplements, any vitamins, and any over the counter medications, because patients may not consider these things medications when you ask them what they're taking. And it's important to convey to the patient an open minded and non judgmental attitude, or your patient may not be honest with you. We need to consider cultural, emotional, psychological, and environmental factors, as reasons why patients may take a particular substance. Physical exams are important to detect underlying existing conditions. It can help to determine adverse effects from a medication versus a previously existing symptom or condition. And lab review is important, especially to detect issues with our kidney or our liver. So, adverse drug effects. All drugs are potentially dangerous. We should remember that our body operates on a series of chemical reactions, and drugs have an effect on those reactions. Unexpected reactions can occur. Adverse effects are undesired effects that may be unpleasant or dangerous, or they may not be. These are other effects in the body besides the intended therapeutic effect. They can range in severity from mild to severe. Adverse effects may occur because the patient is sensitive to the drug or due to the drug's action on the body, causing an unintended response. Adverse effects may also be because the patient's taking too much or not enough of the drug. Our role as the nurse is to stay alert and monitor for drug reactions, to teach patient and family what signs and symptoms to look for, and to intervene to prevent or manage those adverse effects. There are different types of adverse effects. First are primary actions. This can occur when the drug is doing what it's supposed to do, but it's doing too much of it. So, for example, anticoagulants prevent blood clots by interfering with the clotting process. If an individual takes too much of the drug, or if they are sensitive to effects of the drug, so the body reacts more strongly than anticipated, they can have excess bleeding, which is not the intended or therapeutic effect of the medication. Another example is blood pressure medication. For many different reasons, a patient may react more strongly than anticipated to the drug and have hypotension or low blood pressure, with the resulting symptoms of dizziness, weakness, or fatigue. So, what are we going to do about this? We're going to monitor the patient closely for effects, and most likely you'll see the provider decreasing the dose if there's a primary action adverse effect. Adverse effects can also come from secondary actions. These are actions that are not the intended effect of the drug. So, for example, narcotics are meant to manage pain. However, many patients experience constipation due to the effect of the drug on the GI motility. Constipation is not the intended effect of the drug. So, this is a secondary action. What you may be seeing here is potentially the provider might decrease the dose, or we may do interventions to help manage the effects. So in the example that I just gave, we may encourage the patient to increase their hydration, to increase their fiber. Maybe we give a stool softener. Another adverse effect is a drug allergy, also called a hypersensitivity reaction. There is some sort of immune response that occurs that results in an antibody formation. When the person is re-exposed to that same drug, the reaction occurs. There can be cross allergies to drugs within the same class. So you'll hear this as we go through our different drug classes throughout the semester, that we might tell you about a cross allergy that's potential. Experiencing or not liking side effects of a drug is not the same thing as a drug allergy. So, for example, I really don't like to take certain antibiotics because they give me a lot of nausea. Me not liking the fact that I get nauseous when I take an antibiotic does not mean that I'm allergic to the antibiotic. In actual drug allergy, there's an antibody that forms in our system. So there are different types of allergic reactions, but the one that we are going to focus on this semester is the anaphylactic drug reaction. And this is like the TV drug reaction that you think of. This is a severe life-threatening adverse effect. So it's an immediate action. It's a release of histamine. The mucous membranes start to swell because of that histamine release, and the bronchi start to constrict. So the patient's going to have trouble breathing, and that's what you're going to see in your assessment. You can see hives, rash, trouble breathing, changes in blood pressure. So often the blood pressure goes up initially to deal with what's going on. And then if it keeps going, this drug reaction keeps going, their blood pressure will drop and they'll be hypotensive. They'll often get dilated pupils. They'll become diaphoretic or sweaty. We'll see tachycardia or an increased heart rate. They often know something is wrong. They are panicked. They might tell you, I feel like I'm going to die, an impending sense of doom. And if we don't treat this, they're going to go into respiratory arrest or stop breathing. So our interventions include to stop the drug, to administer epinephrine subcutaneously, to notify the provider, and then we always want to prevent. Prevent is better than treating. So once we know they're allergic to a medication, they should wear a medic alert bracelet and carry an EpiPen or epinephrine pen with them. So drugs, unfortunately, can have toxic effects, and dermatological reactions or reactions that affect the skin are very common with many drugs. So what we would do as nurses, we're going to assess the skin for rashes and lesions. We're going to look for systemic effects like enlarged lymph nodes, fever, hepatomegaly, which is enlargement of the liver. So often in the right upper quadrant of the abdomen, you can actually feel that enlarged liver. There's also something called Stevens-Johnson syndrome. This is rare but very serious. It's a potentially fatal skin reaction where the patient has dark red papules, which are small raised areas on the skin or bumps, appearing on the extremities with no pain or itching. Often it's in a ring or circle-shaped patches. Our intervention for mild cases of dermatological reactions like rashes and hives, it's going to be skincare, teaching, don't wear tight clothes, don't scratch, don't rub, don't use perfume soaps or lotions. We can use medications like antihistamines. For severe cases like Stevens-Johnson syndrome, we want to discontinue the medication, and then we'll give medication to treat the issue like antihistamines and topical corticosteroids. It's important to note that rashes can be a common adverse reaction to a drug, not necessarily an allergic reaction. So the difference between a common reaction to a drug versus an anaphylactic reaction is that in addition to the rash, they'd be having trouble breathing if it was an allergy versus a dermatological reaction. Another dermatological reaction is stomatitis, which is inflammation of the mucous membranes. On assessment, we could see gingivitis or inflammation of the gums, glossitis or inflammation of the tongue, difficulty swallowing, bad breath, pain in the mouth or the throat. What we're going to do here is frequent mouth care, frequent small meals with non-irritating foods. So, nothing spicy in there. We don't want to use really temperature hot type foods, nothing rough like potato chips. Getting a dental consultation can help. And then medications for the mouth, being antifungals and local anesthetics, which can numb up the mouth, especially when eating, can be helpful. Another toxic effect is liver or hepatic injury. Liver is key in metabolizing drugs. So remember back to that first pass effect. Oral drugs are absorbed and sent directly to the liver through that portal vein. So the liver cells get the full impact of the drug before it is broken down into metabolites. Any drug metabolites that are irritating or toxic is going to affect the liver. If we already have liver impairment, then we can possibly end up with toxic levels of the drug. So nurses should check liver function lab tests prior to initiating drug regimens and during the regimen. How frequently we would check that would be dependent upon the drug, and we'll be talking about that as we go through the semester. So our assessment for signs and symptoms of liver impairment include looking at our CNS system for fever or malaise, our GI system, so nausea, vomiting, jaundice, or the skin turning yellow, um, abdominal pain, elevated liver enzymes, that would be our AST and our ALT labs, abnormal bilirubin levels, changes in our clotting factors, so our PT, our PTT, and our INR. And that's because some of our clotting factors are made in the liver. Interventions, in most cases, we'll need to discontinue the drug because we only have one liver. We don't need to damage that. We can do small, frequent meals for the GI effects, skin care if they're jaundice, because a lot of times jaundice can cause itchiness. We can do cool environment if they have fever, rest period if they're having malaise. Other toxic effects can happen to the kidney or renal injury. Kidneys are key in excreting drugs. So renal impairment can result in the accumulation of the drug in the body. So nurses should check for kidney function lab tests prior to initiating drug regimens and during the regimen. And just like with the liver, the frequency of how much we'll check those labs will be dependent upon the particular drug. So our assessment's going to be to look for changes in our labs, so elevated BUN or creatinine, a decrease in our hematocrit, and electrolyte imbalances. In terms of symptoms we might see, they have, again, fatigue or malaise. They might be a little irritable. We might see some edema or excess fluid going on. They could get a skin rash, and we could see a decrease in their urine output as their kidneys are being damaged. Interventions include things like positioning the patient. This will help with the excess fluid. If we elevate the legs, if their legs are fluid, if they're having rashes, being careful where we're placing the area with the rash. Diet and fluid restrictions. So if they're having a lot of edema, we'll see a decrease in their fluids that we're allowing them to intake. Skin care in the area with rashes, electrolyte replacement, and rest. They may need to discontinue the drug. If that's not possible, the patient may need dialysis. Poisoning. So poisoning is damage to multiple body systems due to an overdose of a drug. It can result in death, so this is pretty serious. Assessment and treatment will be dependent on the drug that's involved, and emergency and life support measures are often needed if it's severe. Some general central nervous system or CNS effects. Drugs can affect both the central nervous system and the peripheral nervous system. Nerve functioning is dependent on glucose, oxygen, and electrolyte balance. We do have that blood-brain barrier, which helps to protect the brain a lot. However, some drugs do have a direct effect on the CNS, or it messes with the glucose and electrolyte balance, which will result in CNS effects. So what we're going to be assessing for: confusion, delirium, hallucinations. insomnia, drowsiness, bizarre dreams. They can have hyper or hyporeflexia. So this would be overactive or underactive reflexes. Numbness, tingling, or paresthesia. Paresthesia is an abnormal sensation of the skin, often described as tingling or pins and needles, or even seizures. Interventions include safety measures to prevent injury, patient education on safety measures, so no operating a car or other dangerous machinery until you know how you respond to the drug. Orientation as needed, who, what, when, where, and why. So maybe who are you? Who am I? What are we doing? What time is it? What day is it? Where are we? Why are we here? And decreasing the dose or discontinuing the drug depending on the symptoms. Teratogenicity, we talked about this a little bit earlier. It has to do with the adverse effects on the fetus. Drugs can cause death or congenital defects in a developing embryo. Some drugs are known to cause problems. Some we don't know if they cause problems. So it's really a benefit versus risk situation, which will be a discussion between the provider and the patient. But the pregnant woman must be informed and must consent to receiving medications when they are pregnant. Nursing considerations in pharmacology are based on the nursing process, and the nursing process would be assessment, conclusions, planning, implementation, and evaluation. And you're going to discuss this in depth in fundamentals, but we're going to go through how this pertains to pharmacology. So assessment is going to be our data collection. We want to assess a variety of areas and we want to collect our data from a variety of sources. Our patient will be our main source, but we'll also have the family, the chart, other healthcare providers, and pharmacies. So we're going to start with getting a good history. This will include medical conditions. We are not just looking at the medical condition that the drug is needed for, but all medical conditions that the patient has. For instance, if the patient has renal or hepatic insufficiency, kidney or liver problems, that will have a significant effect on almost all medications. We want to know about current drug use. What medications are they currently on? Prescription, over the counter, vitamins, herbal alternative therapies, street drugs, caffeine, alcohol. We want to know it all. If they have any allergies, especially to drugs, and if so, what was their reaction? Finances, we need to have a basic understanding of their financial situation to know if they can afford medication. Literacy and education levels, we're not going to make any assumptions here. There are many people who are functionally illiterate. This information is important to ensure that we give them information at the right reading level for them. Most patient education is now made for a 5th grade level. Remember that stress, emotions, the environment can all play a role in how much is remembered. Is there anything we need to know about their culture or religion that could impact the drug regimen? Oh, I put finances in here twice. I must think it's really important. So again, can they afford their medications? Can they afford the follow-up care that might be needed? Understanding of the disease and the drug regimen. Do they understand their disease? Do they understand the symptoms and effects? Do they understand how and when to take their medication? Do they understand if there's any off-limit foods or other medications they shouldn't take at the same time? Do they understand what could happen if they don't take their medication? We want to make sure that we know if they've had any reactions in the past. This would include drug-drug interactions, drug-food interactions, drug alternative therapy interactions, and drug lab test interactions. Social support, do they have help at home? They may need referrals to some community resources. And then health-seeking behaviors. How often do they follow up with their primary? Do they typically refill medications on time appropriately? Do they take their medications on time? Certain drugs may not be a good option if the patient doesn't have regular access or chooses not to access healthcare regularly. We'll also want to do our physical assessment and exam. This would include their age. The end of the age spectrums are when we tend to see the issues. So younger ages, infants and small children do not have mature organs. Older adults have slower everything, GI absorption, blood flow to muscles, receptor site response. So all of this could affect medication. Weight, we already talked about how it's based on a 150-pound male, so those who weigh significantly more or less may need dose adjustments. Side effects of medications. So, anticipating the side effects of medications allows us to assess that system before administering the drug to get a baseline and to perform assessments to see if they're having side effects. We can also ask the patient specific questions related to the side effects as a part of the assessment. And then knowing the therapeutic effects that we are looking for ahead of time can guide our assessments. We want to assess before therapy is started and once the drug regimen begins to see if we are reaching the therapeutic effect. And then lastly, our diagnostic tests. Depending on the medication, there'll be particular labs that we'll want to look at, maybe even things like X-ray, ultrasound, cardiac tests, depending on the medication. Most drugs have contraindications and cautions, times when a drug should not be given or should be given with caution. One of the purposes of doing our assessment is to identify any of these contraindications or cautions. There are times that it's okay to give a medication even if the patient has a contraindication. It can be confusing to know when it's okay to give a medication and when it's not. So hopefully this terminology will help. So for contraindications, we have absolute and relative. Absolute is life-threatening, never administer. Think anaphylactic reaction. Relative means we will balance benefit versus risk. We need to contact the provider before administration. Caution would mean that it's safe to administer with additional nursing considerations in place. This may be assessing for severity of the disease or interventions such as additional monitoring or timing of the medication. Conclusions, actual or potential alterations in a patient function based on assessment of the clinical situation. In pharmacology, we would be focused on drug-related nursing conclusions, things like knowledge deficit, adverse effects, effects of the disorder that the drug is intended to treat. Planning. In the planning stage, we look at all of the information so far, so that'd be our assessment and our nursing conclusions that we've gathered, always keeping in mind the specific patient we are working with. What are the goals and outcomes for this patient? How are we going to prioritize them? Again, this is pharmacology, so we're going to be focusing on the drug therapy here. Implementation, what nursing interventions will assist in achieving the goals and outcomes we set in the planning stage. Interventions will always include the 3 checks, which you will learn about more in drug administration and skills lab. But this is where we triple check the medication with the patient's medication administration record, or MAR, to prevent errors. We're going to be thinking about comfort measures related to the effects of the medication. How can we minimize or help the patient cope with side effects and interventions? I'm also thinking about patient safety. There is something called the placebo effect. This is the belief that a drug will work, and having that belief that a drug will work can impact if the drug works. So as nurses, our attitude and support can help the patient to have a positive outlook on the drug regimen. Drug regimens often mean that a patient may have to change a long-term habit or a lifestyle adjustment, which can be difficult. We can help patients to figure out how to make the drug regimen fit with their lifestyle and alternatives if they do need to change something. We also can talk to the provider if we determine that the patient is not willing or able to change something that they should. We always need to provide patient education. Information to include in our patient and family education is in box 4.4. And we always want to provide written instructions to our patient about the drug regimen. The nursing process always includes evaluation. We are evaluating for a few different items. How is the patient responding to the drug? Is the therapeutic effect being achieved? How about adverse effects? Are they manageable? Are they tolerable? Is the patient able to handle them? Were the nursing interventions and patient education effective? Did we meet the outcome and goals that we set? Is the patient taking the medication as directed? A lot of time, the evaluation requires reassessment, which restarts the cycle. If our evaluation reveals that our outcomes were not met or we find new items when doing our assessment, then we may need to change our plan of care, and that is okay. Because this information plays such a prominent role in every lecture, I thought it would be helpful to have a quick summary that you can refer back to in the future. In every lecture, we'll be reviewing the key nursing considerations for each drug classification. Nursing responsibilities related to pharmacotherapeutics or drug administration has to do with patient assessment. We always need to complete our assessment steps first, actually administering the drugs, assessing drug effects, so therapeutic effects and adverse effects, intervening when unpleasant or undesirable adverse effects occur, so helping with those comfort and safety measures, providing patient teaching on drugs and the drug regimen, and monitoring to prevent medication errors. Being knowledgeable about drugs or medications is what enables us as nurses to carry out these responsibilities. Sadly, a large number of medication errors are made. It's hard to get accurate statistics. A lot of the numbers are based on estimates, which of course can be very off. However, I think we all can agree that even one mistake is one too many. There's a high cost to medication errors. The actual costs of fixing the error, the costs incurred if the facility reputation is tarnished, and most importantly, the physical and emotional harm to the patient. There are multiple layers of protections in place to prevent medication errors. The layers include the prescriber who orders the medication, the pharmacist who fills the medication, and the nurse who administers the medication. One qualitative study from self-reporting states that out of the medication errors, 39% are attributed to physicians, 38% to nurses, and 23% to pharmacists. This means that it can happen to anyone. At each layer, there are several safeguards. Many of these are built into the electronic system of actually ordering and charting our care. The nurse is typically the final check in the process. I call it the last line of defense because it's the nurse who administers the medication. It's our responsibility to know or to look up how to store and prepare medication, to know why we are giving a medication to a patient, to give the right drug in the right dose via the right route to the right patient at the right time. We also need to document correctly. This includes what we gave when, any pre-assessments that we did, any adverse effects that occur, and the education that was provided. Nurses will also provide the education that the patient and family will rely on when they go home. This would be education about the drug regimen, but also about how to advocate for themselves and ask questions if they are unsure of something or if something doesn't seem right. The patient also has a role in safe medication administration. They need to keep an up to date list in their wallet or on their phone, and this is both for adults and for kids. They should store medications safely, cool, dry places, not the bathroom, away from kids and pets. When giving over the counter medications to kids, they should use only medicines that were made for kids to ensure correct dosing. And then they want to measure liquid medications using appropriately marked devices like medicine cups, syringes versus kitchen spoons, or, certainly not guessing or just estimating. They should speak up if they are unsure of something or if something doesn't seem correct, and they should call the provider if no improvement or adverse effects occur. Medication errors must be reported on both the institutional and national level. The nurse's responsibility is to report the error at the institution they work for. The facility is responsible for reporting it at the national level, and this could be reported either to the FDA or to the U.S. Pharmacopoeia. At the institutional level, we'll follow the policies and procedures at that institution. The purpose of reporting errors is not for individual provider blame, but to see where there may be larger issues that can be corrected to prevent errors. So, for example, children's and adult doses used to be kept close together in the medication cart. Errors were reported, they now are kept separate. If there's drugs that look alike, their names look alike, or they sound alike, we usually catch that through errors that are made, and then we change their labeling to make them look different. We now know that taking over a certain number of patients can increase errors, as can working long hours. So those things are known, and changes have been made to help prevent those issues from occurring. And that's the purpose of reporting errors, is to prevent them from happening in the future. You made it to the end. I know it's a lot of information, really quite a big base for our intro to pharmacology, but I appreciate you listening to the lecture, and I hope you have a great rest of your day.